Good morning, guys. Tony Maritato here, licensed physical therapist, and I wanted to share a story from the clinic today. So I was in the clinic this morning treating a patient that I had treated several times over the past couple of years. She had some questions about possibly scheduling a total knee replacement, and one of the questions was, what were my thoughts as a physical therapist on when she should decide to have a knee replacement? She's been battling osteoarthritis for over a decade now. She's tried the Symvisc injections and other injections. Each time she gets the injection, she does pretty well for a couple months, but she feels like she's just putting off the inevitable. And she asked, how do I make the determination that it's time for a knee replacement? Now, certainly from an imaging perspective, she has osteoarthritis, potentially bone on bone. But I said, one of the hardest things for an individual like yourself to make the decision on getting a knee replacement or not is really determining what you believe is, one, driving the pain, two, driving the potential functional limitations and physical impairments. And so let's talk about that, because if you have or have not had a total knee replacement already, I wanted you to get an experience to see what a therapist would discuss with you in a pre-surgical evaluation, or if you're just even thinking about sometime down the road you may need a knee replacement. I'll give you an example. My wife had an arthroscopic knee surgery probably 15, almost 20 years ago. And after that surgery, the surgeon said, one day you'll probably need a knee replacement. So these are things that are, coming down the road. But I just wanted to share my experience with this patient this morning. So my first question was, what are you having trouble with? What functional activities are you having trouble with? What can't you do that you want to be able to do? And she said, well, there's nothing really that I want to do that I can't do. There are times that the knee hurts. It's painful. Most often going downstairs, carrying a load of laundry or groceries downstairs will increase my knee pain. Doing too much physical activity. She stated specifically she was unable to kneel on her knee. And I said, well, as much as I talk about kneeling on the channel, there are a lot of people who are sensitized to kneeling after a knee replacement. So don't get a knee replacement because you want to be able to kneel in the future. There's a chance you won't be able to kneel after a knee replacement. I also went through the stats that upwards of 20% of people never have less pain, or some of them have more pain following the knee replacement. So, that's not exactly like the most amazing outcome. But as we continued the conversation, before I started any kind of physical exam, she was telling me that she would get these injections. The injections run a couple $1,000s, and she's just not sure that she wants to keep putting the money in if the knee replacement is going to be the best option. But functionally, she's able to do most of what she wants to do, most of what she needs to do. And it's really more the frustration of when the knees act up. Quote, act up, meaning when they become more painful. So then I began the physical exam, and we were sitting together. I asked her to sit up on the table, a treatment table. You can imagine just a medical exam table. She was sitting there, and I sat in front of her, and I poked around on the knee. And literally the moment I came close to the patellar tendon, which is the tendon that connects the front of the knee, immediately she jumped. And immediately there was a sharp piercing pain associated with that. So I moved away and I touched other areas that were not painful, and I came back to the patellar tendon, and again I got the immediate same pain response. So I said, well, the good part of this is the patellar tendon, and I showed her on a computer what the patellar tendon is and how it functions. I said, technically this is not a tissue that would be involved in the total knee replacement. So I explained the total knee replacement would remove the top of the tibia, the bottom of the femur, potentially the underneath side of the patella, the kneecap. But I said the patella tendon and the pain associated with what you're feeling right here would be more of a patellofemoral syndrome rather than associated with the osteoarthritis in the knee. So I said, let's continue the exam. So I checked the joint lines, which don't worry if you don't understand what I'm saying, but basically I'm checking the meniscus and the cartilage that I can palpate, and there was no pain there. But when I came around to the lateral aspect, the outside of the knee, there was again that jumping, flinching, immediate pain response when I touched the fibular head. So if you've seen some of my other videos, there's a bone that runs along the outside of the lower leg that's called the fibula. And at the top of that, the fibular head, the top of that bone, it works with the knee, but again, it's not really a tissue or bony structure that's replaced during the knee replacement. Yes, you can have osteoarthritis, you can have sensitivity, there's a peroneal nerve that runs in that area, but it's not really going to be improved with a knee replacement. So again, we found a sensitized tissue that was tender to palpation, but would not necessarily improve with a knee replacement. And so as we continued to work through the structures, there was a little bit of swelling in the back, so we referred to that as a Baker's cyst. But what we were finding was a lot of her sensitivity, a lot of her tissue that was driving the pain response wasn't necessarily the articular cartilage, the meniscus, the stuff that's going to be affected by the knee replacement itself. Now, the real story, and I am as frank and candid with every single one of my patients as I can be, is I said, if you had the knee replacement, if you went in and you saw the imaging and you said it's bone on bone and I've got knee pain, and the orthopedic surgeon made the determination that a knee replacement was the right thing to do, there is a very good chance that those tissues, while not directly associated with the knee replacement, those tissues would improve. Why would they improve? Well, a component of it is the disruption to the knee joint and the rehabilitation process of the knee replacement itself could be enough to stimulate the repair in those other sensitized tissues. Even though they weren't necessarily what was involved in the knee replacement, they're going to get the secondary benefit of having the surgery and then the recovery process from the surgery. So there's absolutely benefit that goes along with that. There are some great landmark studies that were done that looked at arthroscopic surgery for a knee, where the study basically went in, they did a real surgery, real arthroscopic debridement for a group of knees, and then they did a situation where they poked the holes in the skin so that it looked like you had the surgery. The surgical team went in and verbally made all of the same words and sayings and everything as if you had the surgery. But at several episodes of follow-up, the patient who had the sham surgery actually had better outcomes than the patient who had the real surgery. So these are published studies that you can go and research, and it's been repeated. And it's really interesting to say, well, why would that happen? Why would the person who had the fake surgery actually do better than the person who had the real surgery? That's a topic for another discussion. But what's important for me to share here is, number one, we want to know what the goals are. If her goal was to kneel again, and in no way could anyone ever guarantee that she would be able to kneel again even after the knee replacement, that's probably not a good reason to have a knee replacement. If her goal was solely to eliminate the pain, and we can find and determine based on manual exam that the pain isn't necessarily associated with the cartilage and the arthritic structures that are involved in the knee, because we know from imaging studies a person can have degenerative changes without pain, a person could have pain without degenerative changes, and everything in between. So degenerative changes by themselves are not a good indicator of somebody who's going to have pain or a positive or negative outcome following surgery. We have to dig deeper, and we have to look at more of the person's specific context, more of their case history. So in this individual's case, I said, here's the question. You're in your late 50s. Certainly knee replacements are happening in younger populations. We do believe that probably having it done sooner rather than later may lead to a better outcome because you're healthier and better able to handle the recovery. But what would happen in your particular case, and this is the patient I'm talking to, what would happen in your particular case if instead of having the surgery, you took the next 3 months, you dedicated that time to all of the same stuff you would have done had you had the surgery, and then see what happens? Because knee replacements and osteoarthritis in the knee, it's one of those things where, you know, we understand that increased activity could be associated with increased pain. But if you're going to have the joint replaced, it's not like you're doing irreparable damage to the joint surfaces and now you're going to have to live with that damage for another 20, 30 years. It's one of those things where I try to liken it to a used car that I know I'm not going to resell. I know it's going to the junkyard for demolition. So if it falls apart, sooner rather than later, at least I have a chance at recovery without the surgery. It's one of those things where I would never, ever, ever recommend somebody push through the pain. But you have to assume if you're going to have a knee replacement, but you're trying to avoid a knee replacement, maybe a medically supervised physical therapy plan of care is going to be an option that could buy you some more time, that could push the surgery off. And we've had cases in our clinic, I'm not saying they were often, but we've had cases in our clinic where somebody was planning a surgery and they came to physical therapy. We went through the program, the protocol, and all of a sudden they said, you know what? I'm feeling pretty good. I'm not going to have surgery just yet. Doesn't mean they never have surgery, but it means that they've improved enough of the variables that they decided they weren't ready for surgery right now. So I would tell you that one of the main things when you're thinking about having a total knee replacement and you're gathering the information and you're looking at all the variables, I would strongly encourage you to find a physical therapist that you know, like, and trust, somebody that you can connect with, somebody that is kind of on the same wavelength as you, that you can run these questions by, that you can run these ideas through, and that will do a physical exam. We'll sit down with you and talk to you and ask you questions and really get to the heart of what do we think is going on? What are the potential outcomes, positive and negative? What other options do we have? And now let's take all of that information and put it together into a plan. And there is no right or wrong answer. We have no idea. We're making the best clinical judgment decision that we can, but at least you have one more piece of the information and a little bit taking from that therapist's experience with other patients that might give you a little more confidence in the decision that you do make, because there is no wrong decision in this case. So guys, I hope that was helpful. If you have more questions, if you have more ideas, let me see, where is it? Right there. YouTube is recommending a video for you to watch. You can check it out. Otherwise, look through the channel and we have lots of other information about questions patients are commonly asking. I'll catch you guys on the next video.